All right, everybody. I wanted to do a quick little thriving video on anatomy of a trauma. So, what happens when you are the anesthetist, nurse anesthesiologist on call, and a trauma rolls in? And specifically for this one, I'm going to talk about more because I mean, we could go into a million different traumas that happen, but I'm going to kind of tackle this from the lens of like hemorrhagic. So, like, whatever car accident, a fall, a farming, accident, whatever you can think of, a domestic situation. We're going to look at this from bleeding, but essentially want to give you kind of the pearls and kind of set the foundation for you of what you need to be thinking about, what your goals are going to be for any type of trauma, and kind of what it looks like to manage it. All right, anatomy of a trauma. So you guys recognize this. This is what they call like the lethal trauma triad. So for me, usually if there's a big trauma that comes in, we immediately get paged. Anesthesia has to come and respond to that to help, which usually, as you guys know, you need all hands on deck, right? So just like the big overview is this is essentially what's called the lethal trauma triad. You guys probably learned this before. And my background was actually in trauma when I was a ICU nurse, when I did critical care, when I did ER. I was a trauma nurse, right? Um, that was kind of my thing. So these are the things that are going to harm or kill your trauma patient, which if we know what's going to kill them, then we know what we need to do to fix them. So the big thing is the coagulopathy, the metabolic acidosis, and hypothermia, right? And we know that coagulopathy and hypothermia do also go hand in hand, okay? So let's say your patient, you're going to the ER, they called a trauma red. It is a huge hemorrhage situation, right? Guys, we're always going to go back to basics. What do we have to do is we have to secure that airway, right? We usually run to the head of the bed. Plus, it's also helpful if we can get the airway under control, then the ER physician can look at assessing injuries and kind of work on other things like that, right? So obviously, big thing is oxygenation. Obviously, what kind of trauma is it? Do we need C-spine precautions? Is this trauma cord injury? Is this a spinal cord injury? Is there facial trauma, right? Is there edema to it? Sometimes a lot of edematous. Is it burns, right? So all those things you have to think about that are going to make intubation potentially difficult for you. And then you want to also think about what you're going to use to get this patient to sleep. Some people, they might come in without a pulse, to which you're doing ACLS while trying to kind of, fix obviously these other things that are going on with the patient. So that obviously is crystal clear. You just pop that, pop an airway in depending on what it looks like. Do you need to get ENT involved? Do you need a surgical airway? Sometimes general surgery can help out with criking the patient. Stuff like that, right? So all those things you want to think about with securing the airway. Now, as far as if you have somebody who is somewhat still alert and awake and etc., the main thing you want to do is, take their memory away if possible, and obviously sedate them in a safe way. Scopolamine patches, because scopolamine does cross the blood-brain barrier. Those have been known to be given in traumas to kind of help make them kind of loopy and forgetful, especially if they're super unstable. Ketamine is kind of my go-to. You might want to think about a little Versed as well, depending on the patient, to help kind of erase this traumatic, thing that they're going through. But ketamine's usually a big one. Now, succinylcholine versus rock. Now, any type of crushing injury where we're worried about a high potassium, we'd want to stay away from sucks, right? Because sucks is going to have more potassium pop out of the cell. It's a depolarizing neuromuscular blocker. So that might not always be appropriate for specific trauma patients. And then usually your other one is rocuronium, which usually if you give a high dose, it'll work pretty quickly. And that's another thing to think about. Are you going to be able to ventilate this patient? Is there debris? Is there stuff that you're going to be pushing down into the airway? So all those things to think about. I mean, I could probably talk about airway and trauma for forever, but I just want to give you guys a brief overview so you guys can go off and into your way and have this good foundational stuff. But just stuff that I want you guys to think about when are securing that airway. Usually grab a second pair of hands, have the glide scope, have the fiber optic, all those things in there as well when you're securing the airway. Suction, all that good stuff. Usually have respiratory there as well for like an extra pair of hands. Okay. So that's kind of number one, obviously the first thing we're going to do. And then it's about obviously airway, breathing, circulation, perfusion, right? So the big thing is getting access, because this patient, especially we're talking about the really hypovolemic ones, is we need some sort of access. So depending on what the trauma is, a lot of times they'll come in with IOs, which can be hit or miss kind of depending, but usually we'll have an IO. The ER team, the trauma team that's in there will usually be working on getting you 16 gauge, getting the level 1 infuser. They'll be getting that up and going. You know, and you can also drop a cordis. You can grab a cordis, get that dropped in. It kind of depends on the situation. Sometimes I've done that once I've gotten the airway secured. Sometimes I've helped them with lines, you know, femoral lines, or sometimes what you have to do in terms of a trauma. Sometimes you can drop a cordis in, like I said. But helping get those big lines in, 16, 18 gauges, et cetera, are kind of your next thing to kind of help them with once you have that airway secured. Sometimes we've even gotten them to the OR pretty quickly. And sometimes if I'm up kind of managing the blood and doing all this other stuff and ventilation and stuff like that, sometimes a surgeon will just drop the fem line ins. But this is, you know, a line in, femoral lines in, access. You guys can get these patients up and going, right? So that's the hypovolemia piece. Another thing to quickly talk about is what do we give these patients, right? Especially in a hemorrhage situation. So usually you'll activate the mass transfusion protocol. Make sure you I would grab something, talk to blood bank or see what you guys have, is see what comes in there, like see specifically what, you know, your facility kind of has. They might be a little bit different. For the most part, you activate your mass transfusion protocol. We usually have a 1:1:1 ratio or a 2:1:1. So if your RBCs, fresh frozen plasma, and then you have your platelets, right? And another big thing is actually they have been getting fibrinogen levels in trauma patients. So you'll hear them, you know, they'll get the full panel of labs drawn out. Usually your team will, you know, the team that you're with will do that, or depending on the situation, you might be doing it if you're dropping in lines. You know, all that good stuff. But getting a fibrinogen level is really crucial because it's actually the first fibrinogen is a pro-coagulant, right? So it's pro-clotting the blood, pro-stopping the bleeding. And that's actually the first procoagulant to get low. So getting that level in, and then obviously giving some cryoprecipitate is actually how you treat that. Okay, so something to think about. So you've got the level 1 going in the OR, and in there, you want to get your fluid warmer. You want to run all the blood, everything through the fluid warmer, because as we know, these blood products are kept pretty damn cold. I think I read they're like 4 degrees Celsius, right? They're cold as hell. So you want to make sure, you know, obviously we're getting the level 1 going, but you also want to get your warmer, your fluid warmer in the operating room ready to go. Warm blankets, bear huggers. I mean, I've had it where I've had like 3 bear huggers on the patient, like obviously like wrapped not around the surgical, away from wherever the surgical site is, but trying to warm patients up, especially if these traumas happen and you're in the cold state of Illinois, Chicago area that I'm in, right? So these are kind of all the things that you are doing, because overall, coagulopathy, hypothermia, metabolic acidosis, all it's going to do is decrease that heart's performance. And guys, from being a trauma nurse, I mean, it's funny, like now I'm in the OR, like receiving the patient, like I go to the ER, help them get stabilized, run to the operating room, get set up, meet the patient there. But I mean, guys, stick of epi, like I would have a stick of epi with me whenever we were transporting our trauma patients to the OR. And honestly, the other day we had a patient come in that was very hemorrhagic. And I literally, like, as we were getting the patient on the table, I was like, guys, I have a really crappy freaking pulse. And I gave a little bit of epi and it just got me through until we were able to keep resuscitating. So always have a little stick of epi ready to go in your pocket or on top of your anesthesia machine, just like a little side note. Okay. And the main thing, obviously, is we want perfusion. Okay. So these are kind of all the things that are happening. We're throwing the kitchen sink at them. You're very busy, right? And then we get into the operating room. And usually the goal is, you know, we want the surgeon to get the bleeding stopped, right? Like, and that's the thing, is you're resuscitating, you're doing all the things, like you're getting all right, how many RBCs are we at? You know, how much crystalloid are we giving? Because really the main thing is you don't want to flood them with a lot of crystalloid. You want to give them the blood, the platelets, the, you know, plasma, and you're just basically like a machine, just like running that. It usually takes a couple of you. I always keep all the bags. I just tack them all on the floor. I keep everything kind of somewhat neat so that I can chart, obviously later, because you will chart once you get this patient to the ICU. You're not going to be charting. You're just going to be writing things down here and there, trending your vitals, et cetera, but you're going to be doing a lot of moving and shaking, right? So we've done all this stuff. So now what happens? So usually you get the patient, you're continuing to resuscitate them, and eventually you hear those magic words. The surgeon's like, I got the bleeder, right? So once you've got the bleeder, you can breathe a little bit, right? So now we can just focus on getting this patient like stabilized and kind of fixing all the stuff that's happening due to what we're giving, right? The metabolic acidosis, what the coagulopathy, all of those things, right? So usually every patient's going to be different, but usually you grab that first ABG, and this is essentially what you're going to see. Your pH is going to be in the toilet, right? It's going to be like 7, 7.1, 7.2. It's going to be pretty gnarly usually. Your CO2 is usually going to be jacked up, right? It's usually going to be very high. Your hemoglobin, depending on where you're at with resuscitation, it's still going to be probably a little bit low. Hematocrit's going to be low. Your calcium's going to be low. And essentially, your potassium could be low too, because when you're giving mass transfusion, right? So number one, your calcium is going to be low because of citrate. The RBCs, there's citrate in there for the storage of them. They're going to bind up your calcium. So your calcium is going to drop. When you drop your calcium, you drop your contractility, your blood pressure drops. It's this whole vicious cycle, right? And then you get the hypokalemia is usually there because it kicks out, like the hydrogen ions get kicked out of the cells. There's this whole kind of and you can actually go into metabolic alkalosis as well due to the blood products, and if the kidney's not able to get the bicarb going. Yeah, guys, remember that, the hamburger shift, all stuff like that. Yeah. So you can actually have like a low potassium, plus depending on how much they've lost, right? So you can either have low potassium. Sometimes you can also have high potassium, hyperkalemia. If the blood products have been stored long-term and they're infused very quickly, you can also get hyperkalemic. But my latest one that I had, the patient ended up being hypo. So now that we've got this, so now what do we do? And as you're fixing this, we'll talk about this in a second, remember what your goals are. So these, I want you guys to think about, these are going to be your goals with this. MAP 60 to 65, oxygen about 92% or above, temperature greater than 35, hemoglobin 7 to 9, INR less than 1.5, fibrinogen between 1.5 to 2, platelets 50K at least, and your pH back in normal range. Okay. So just have these in mind as you're doing this. So now we've got the bleeding under control. We've been resuscitating, right? We've got all of our lines, all of our data. So now we need to fix this. So few things you need to do is obviously ventilation status. Usually I will jack up that respiratory rate pretty damn high to keep blowing off that CO2 so I can help get that pH to a more higher, better level. So ventilation, another, high respiratory rate. I usually don't use any PEEP when they first get into the room because I don't want to drop their venous return or their cardiac output even more than it is. I might gradually start to put some PEEP on to kind of help if once we get kind of stabilized, but initially I don't really put a lot of PEEP on for that reason. So that's some things that you can do with your ventilator setting. Usually run them on 100% FiO2, and then you can kind of titrate that down as needed, but usually I just want oxygen. I want my normal kind of tidal volumes and then a high respiratory rate, like depending on this. Keep transfusing, obviously get that cryo. I really would recommend getting some cryoprecipitate in as well as you're giving the platelets, the plasma, everything like that, communicating with the surgeon, where he's at, what it looks like, blah, blah, blah. Calcium, I usually tend to use calcium gluconate. It's not as tough on the veins, but obviously if you have a central line, you can do calcium chloride. But I give 1 to 2 grams of calcium, and then potassium, I usually grab things. We have a cardiac room, so I'll usually have the nurse grab me stuff in there, and you can start a drip of potassium. Also, depending on your vitals as well, this is the time where you want to think about pressors, right? Like, because basically what's going to fix a situation is volume. These patients need volume, need fixed, overfixed, right? And so usually like you give that, but sometimes you might need a little bit of a pressor. So getting some epi on board, usually getting some levofed. Those are usually the two that I usually go to in this in low dose. You might need a little bit of that. Bicarbonate, you might be needing to give some bicarb as well. Okay. So those are kind of all the things that you're doing once you get a little bit more stability, throwing a bis on these patients, because the really thing you're keeping the gas super low, obviously, to do their instability, is not having them aware. Eventually, I might work in a little bit of fentanyl, because fentanyl's cardioprotective, right? I love fentanyl. You can give like low doses. So eventually I'll start like getting some of that in as well. Um, and then, so you do this one round, you tweak, you fix, you get your stuff in, then you grab another ABG, and usually that one's progressively getting better, right? Your calcium's a little bit better. Usually your K's normalize, whether it's, and if your potassium is like super, super high, then obviously you guys know what to give, right? You guys can give, remember the good old days? I mean, we really don't do like K-Exolate or anything like that. Insulin helps get it back into the cells. Usually have to give some glucose with that, your beta agonist, stuff like that. But guys, remember also what will drop your potassium as well as your calcium. So also think about that. If you do have a normal potassium and you're giving calcium, that relationship there, because calcium's a treatment. If you have hyperkalemia, you can actually give calcium to help treat that, right? So all those things to be thinking about as you are managing this patient and titrating them. So I usually get about 3 ABGs by the time we are done. And then the next step is getting them into the ICU, getting reports, getting things cleaned up, getting everything charted. And then from there, there's a whole other host of things that, can happen. The IC, this patient might be coming back to your OR for multiple surgeries, the sequela of, pulmonary embolism after traumas and stuff like that. So a lot of things happen, but I just at least wanted to give you guys an overview of kind of that basic management and what that looks like. If you guys have any questions or anything like that, please let me know, and hope you guys have an awesome day. All right, guys, happy anesthesiaing out there. Bye.